السلام عليكم ورحمة الله وبركاته. تسمعوني؟
Recording in progress.
تسمعوني؟ اوكي. We start. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم. آمين وأجمعين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل. آمين يا رب العالمين. Here we have a patient with case discussion. I submit this case on my Facebook page on May 8th, and we will discuss this case. What are the findings and what are the differential diagnosis and the final diagnosis of this case. The patient has previously history of acute bacterial infection and with now presented with fever. Here the patient, where is you think the lesion is pulmonary or extrapulmonary in location? Where you think the lesion is pulmonary or extrapulmonary in location, you can write on the chat, no problem, if you don't want to talk. Okay, the lesion is here. It is an extrapulmonary lesion. The lesion here, it is extrapulmonary and pleural-based lesion. Is the lesion is pleural-based? As we said just now, it is a pleural-based lesion. And the lesion has obtuse angle or acute angle with the chest wall. What do you think? The lesion has obtuse angle or acute angle with the chest wall. This is the angle. It is obtuse or acute angle. You can write in the chat. So the lesion, it is an obtuse angle with the chest wall, as we see here. The lesions in this image, it is acute or acute angle, yes or no? This is the lesion here in the red. It is acute or not acute angle or obtuse angle. It is acute or yes or no? The lesion here has an acute angle with acute angle with the lung. And here, this is the lesion, as we see in our lesion. This is an obtuse angle, and this obtuse angle lesion can be seen either in the mediastinum or pleural or extrapleural location. So in the chest wall, including the pleural spaces, extrapleural spaces, and also in the mediastinum. Here, the two patients we have with acute angle, as we see here. This is the acute angle. This is the acute angle. This is indicating that the lesion, it is a pulmonary lesion with this acute angle, or sometimes it is called a claw sign. And here the lesion with obtuse angle, it is like our lesion. And this lesion, it is an extra pulmonary in location with extra pulmonary location. The obtuse angle, as we said, can be seen in the other lesion arising from the chest wall and invaded the lung, or on the from the pleural spaces, or from the mediastinum. Here the lesion, it is lenticular in shape, yes or no. It is the lesion here, as we see here, it is lenticular in shape. Lenticular means that the lesion, it is biconvex, and the lesion, it is biconvex, and the lesion, it is a biconvex here, and it is biconvex, and it is suggestive of the diagnosis of a fluid in the pleural space. And the lesion, as we said, it is lenticular in shape, or sometimes it is called D sign. It is the D sign here, or sometimes it is called pregnant lady sign. So this is the same as lenticular in shape, or D configuration of the region, or a pregnant lady in the pregnant lady sign. Here we have the link here, and the link is to share the, if you want to receive a certificate of the attending the lecture. Continuation, you think the fluid is in this patient is a free or liquidated fluid? As we discussed, the patient has liquidated fluid in the pleural space. Why? It is liquidated because it is not giving the shape of the free fluid. How we can detect the free fluid? We can detect the free fluid with the decubitus view, and here we see the fluid, it is a free fluid, and in the right side of the lung in the right side of the pleural space. How we recognize it is a loculated effusion or not? What is the significance of the loculated effusion? Loculation should be considered when the density or is considered a fluid and does not correspond to anatomical location of the fissure. As we see here, it is a fluid in the minor fissure, fluid in the minor fissure, and on the lateral view here, we see fluid in the minor fissure and the major fissure here. So once the fluid, it is not in these spaces and it is we call it loculated. If it is correspond to anatomical location like the fissure, it is not a loculated fluid, and it is in the loculated fluid, it is not a gravity dependent location, and we consider all liquidated effusion as empyema until proving otherwise. We consider liquidated effusion as empyema until proved otherwise. What are the features are suggestive of an empyema? Features suggestive of empyema include enhancing thickened pleura. We call it a split pleural sign, whereas the pleural effusion has thin, imperceptible pleural spaces. Locules of gas absent unless recent thoracenthesis, and obvious septation and associated consolidation or associated infection, like in the vertebra or in the subdiaphragmatic area. We see some examples of this. Here, this is our patient. He has empyema in the left side, a pleural space. As we see here, it is thick, enhancing a thick, enhancing parietal pleural here, and enhancing the visible pleural and parietal pleural. And this is the compressed lung, and this is the split pleural split sign, split pleural sign. And this is another patient with a pleural split sign on the right side in empyema, and this is the visible pleura, and this is the parietal pleura, and this is the fluid. Here there is some gas locules noted on the pleural cavity with a pleural split sign. The gas can be due to gas forming organism or due to bronchopleural fistula or recent intervention. Here, this is the ultrasound of the normal free fluid, of the free fusion on the right side, and in patient with empyema, as we see here, with thick septation in the empyema fluid. Also, the ultrasound, it is help in the intervention to localize the intervention site. Here, this is a CT scan with patient with localization, and that localization and associated with the adjacent inflammatory changes, and the patient here with empyema with localization and adjacent inflammatory changes. Here, this is another patient. As we see here, patient with empyema with extension to the chest wall, and we call it, this is empyema necessitatus. Here, this is another patient with thick, with empyema on the right side and with some calcification here, and on the CT scan it is organized calcification empyema with air fluid level. Here, this is another patient with empyema with calcified and organized due to tuberculous empyema. And please don't forget the differential diagnosis of pleural calcification can be due to old empyema, old hemothorax, asbestos, inhalation, silicosis, talc exposure, and malignant pleural mesothelioma can be seen in the 5% of pleural calcification. MRI, sometimes it is useful to differentiate between transudate and oxidate, and especially the diffusion weighted image. And if there is any involvement of the soft tissue and the chest wall or spinal involvement. How we, it is empyema versus a pleural effusion. Empyema form, as we said, an obtuse angle with the chest wall, and it is unilateral or markedly asymmetrical, whereas the pleural effusion are or if of any significant size, usually bilateral and similar in shape. Lenticular in shape empyema, as we said, it is a biconvex, whereas in the pleural effusion, it is a concentric in shape, concave toward the lung. We call it meniscus sign, and we see some examples. Here we have VHS. As we see, the right side, right costophonic angle is obliterated, and we need at least 75 milliliter of fluid to obliterate the right costophonic angle or left costophonic angle in the BA view, and we need to obliterate the costophrenic angle or in the lateral view in about 175 to 200 cc to obliterate the costophrenic angle on the lateral view. Here we have bilateral pleural effusion, and we see the concavity here, as we said, and this is a meniscus sign. And here another patient with right-sided pleural effusion, and we see the concavity spheroid in shape, and this is the meniscus sign. Here we have the pleural effusion, uniform density, and the meniscus sign, the concavity on the left side. Here, patient with the fluid in the minor fissure, as we see here. Here, another patient with cardiac enlargement with bilateral with subpulmonary effusion, as we see here the diaphragm, both diaphragms elevated. How we can differentiate empyema from pulmonary abscess? On the blame film, the shape, the abscess is usually but not always round in all projection. An abscess may form an acute angle with the costal surface or the chest wall. Empyema, as we said, not always, but it is lentiform and has obtuse angle. Here, this is a patient with lung abscess on the right upper lobe. As we see here, it is peripheral in location, and we have the acute angle here. This is or close sign, and also with air fluid level, and also it is rounded in shape. Rounded in shape with air fluid level with acute angle here. Here, another patient with abscess surrounded with associated with adjacent inflammatory changes adjacent the abscess. In Empyema versus abscess on the CT scan, abscess as will interrupt the bronchovascular marking, and empyema usually distort and compress the adjacent lung. Split pleural sign in empyema, thickening and separation of the visceral and parietal pleura is a sign of empyema. Wall, abscess has thick wall, thick irregular wall, empyema usually smooth, also associated with thickened wall. Angle with the pleura or the chest wall, abscess has acute angle, with empyema has obtuse angle. Pleural enhancement, empyema tend to have short pleural enhancement. Edema or heaviness of extrapleural fat tend to occur in empyema. And here we have patient with empyema with enhancement of the pleura. This is the parietal pleura, and this is the visceral pleura. And here patient with abscess and with thick wall abscess. Uh, Thank you for listening and hoping to see you soon in another talk. Here the link, and we can uh, register, and you can also receive your certificate of attendance of the of this talk. And please fill the request form, and uh, request form, and you can receive of the certificate of attendance immediately. This is the link for to fill it and to receive your certificate of attendance. Thank you very much for listening, and hoping to see you soon in another talk.